Hello everyone, welcome to the latest Queen Elizabeth Scholarship webinar from the McMaster Health Forum. We're coming to you today from the forum here at McMaster University in Hamilton, Ontario, Canada. Quick agenda for our webinar today. I will tell you a little bit about the McMaster Health Forum, a little bit about the Queen Elizabeth Scholarship Program, and then I will introduce you to our Queen Elizabeth Scholar presenter, who is Paddy Sreeram, who went to Australia and worked with the New South Wales Ministry of Health. So the McMaster Health Forum is a leading hub for improving health outcomes through collective problem solving. We harness information, convene stakeholders, and prepare action-oriented leaders, and act as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and individual universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The version of the Queen Elizabeth Scholarship Program that is offered at the forum is called Strengthening Health Systems. Our scholars contribute to strengthening health systems and become part of our large and growing network of health system leaders. We've had 2 cohorts of scholars so far. On the screen now is our first cohort who went away primarily in 2016. And this is our second cohort who primarily went away in 2017. Our presenter today is Paddy. She is currently a global health specialization student in the Bachelor of Health Sciences undergraduate program at McMaster University. As a research assistant and fellow with the McMaster Health Forum, she has conducted rapid reviews of evidence, supported the maintenance of health systems evidence, translated evidence into plain language summaries, and improved student engagement with health system challenges. Paddy hopes to build upon her QES internship experience at the Research Policy Interface by combining her interests in advocacy, innovation, strategic planning, and population health and addressing health inequities moving forward. So, without further ado, I will turn it over to you. Here you go.
Thank you, James. I hope everyone can hear me. And excuse me, I'm just recovering from a bit of a cold, so I will do my best to sound alive and well. So, my name is Paddy, and I want to speak today a little bit around my experience at the New South Wales Ministry of Health, and I was there from around mid-May to mid-August, and just wanted to tell you a little bit about, just figuring out technology, so a little bit around what the similarities and differences are between the health systems in Ontario and New South Wales, so a bit of an explanation around why did I choose Sydney. Sydney, New South Wales to study and conduct my QES experience, and then I'll speak a little bit around the projects that I conducted and give you a bit of a high-level summary of the types of initiatives that I took on and that were assigned to me. I'll be giving a really broad and probably vague overview because I took on a breadth of projects, and it's difficult to get into the details now, but absolutely if you have any questions, do email me. I have my email at the end of all the slides, or feel free to ask me any questions in the Q&A. A part that I really wanted to focus on in this presentation is sort of the impact of the work that I took on, so that'll probably take up a good amount of time during my presentation, and then also focus on what I took away, so some of the key lessons for me and what I think are some important directions for the field of health system strengthening going forward. Then I want to talk about how sort of the implications of my work, so what does it matter about what I did, and how can I apply it here back in Ontario, and then obviously go through the acknowledgements of some of the people and organizations without whom I could not have completed this excellent experience. So I'll get started. So this slide was in here initially when I was presenting to my colleagues in Sydney, actually, to let them know what university we're from and where the forum is situated. But just as a reminder, I'm currently in my 4th year in the Bachelor of Health Sciences program, and I've been involved with the forum for the last almost 2 to 3 years now in the health systems field, and both as a research assistant at the Impact Lab and then as a fellow. And that's where I, applied for the Queen Elizabeth Scholarship, and thus began my journey from Hamilton, Ontario to Sydney, New South Wales. So the reason that I chose New South Wales in the first place is because just that earlier semester I'd been taking a course that's offered and run by members, leaders of the forum, so Dr. Lavis, Dr. Wilson, and also James, in health systems policy and, oh wow, I've forgotten the course code, but essentially health policy and health systems. There we go. And what we did was we compared the two health systems, Ontario and New South Wales. So I already had a bit of a background going in, and I realized that there are a lot of similarities between the two health systems, and that being said, just enough of a difference for me to learn something new and see how I can apply some of the technologies and sort of systems that are in place right now in the New South Wales health system, and how might they be applicable to Ontario. So I'll just go through a bit of key details. You can see that there's a difference in population. Ontario has basically double the population of New South Wales. I will say that the Ontario population is more recent data. It's from July 1st, 2017, and the New South Wales population data is based on the 2016 census from the Australian Bureau of Statistics. And then I also wanted to highlight some of the differences and similarities in how their health systems are set up. So both of them have shared health systems decision-making between levels of government, although there are a few differences. So in New South Wales, the Commonwealth has a bit more decision-making authority, and the states are more responsible for the delivery of care, whereas in Ontario, obviously the province has a lot more decision-making authority, and the federal system takes on more niche areas as opposed to decision-making authority across a lot of different sectors, health sectors. Next, they're also financed pretty similarly, so taxation makes up a huge part of the revenue, the public revenue, that's used to finance the health system, whereas in New South Wales, private insurance does make up a bigger fraction of the revenue used to finance the health system. And then finally, one of the major differences is that in New South Wales, they have public provision of health services, so there are a lot of health system, so state-owned and operated hospitals, whereas in Ontario, most of them are private, although our physicians are paid through OHIP. So these are some of the main similarities and differences, and I'll just jump on to the next part around my project. So this is the team that I worked with in New South Wales. I won't go through all their names, but I will say that all of them are phenomenal. So I was working in the Center for Epidemiology and Evidence at New South Wales Health, and specifically in the Evidence and Evaluation Unit. So if you think about a ministry, a lot of people are decision makers, but where I was particularly situated was a very research-heavy side of the ministry. So it allowed me to be at the forefront of that research policy interface that I was talking about in a bit of my bio. And I'll speak a little bit more to what I've learned from being at that interface between policy and research. So I'm just going to go through some of my projects. So the first one that I was assigned was to design decision support tools to scale up population health interventions, develop program logics for population health training programs, prepare a manuscript for the Aboriginal Maternal Infant Health Service Evaluation Protocol. Don't worry, I'll be explaining what all of this means soon. Just wanted to give you an overview. And then these last two projects were smaller scale and ones that I took initiative on, so they weren't assigned to me, but I thought I would use the skills that I was bringing as sort of a forum researcher to see what might be useful in that ministry setting. So those include creating a resource for finding and using research evidence, so that involved adapting the forum's resource to help suit their needs at the Ministry of Health, and undertaking a strategic analysis of funding recipients. This last one is intentionally quite vague because I realize a lot of those documents are classified, but I did want to mention that I did play a part in sort of conducting that analysis. So to start, I wanted to give a little bit more detail into what are these decision support tools, what is scaling up population health interventions, and what was my role in all of that, and what does that look like now. So I'll just keep moving. So specifically in this context, scaling up refers to the deliberate efforts to increase the impact of successfully tested health interventions to benefit more people and foster policy and program development on a lasting basis. So all parts of that definition are actually really important. So they're deliberate efforts. They have to increase the impact. It has to be successfully tested interventions, has to benefit more people, and it has to be sustainable, so the piece around lasting basis. So in 2013, the New South New South Wales Ministry of Health released this guide on scaling up population health interventions, and what it does is it offers a comprehensive step-by-step processes for scaling up health interventions, but it doesn't provide a practical tool to conduct scalability assessments of promising interventions. So it gives you a lot of the, let's say, theoretical background around what you need to understand, but when it actually comes to scaling up these population health interventions, there isn't currently a tool, or there wasn't when I started, and now by the end there was, and that's something that we're continuing to develop. So I'll just skip forward for a second. So to develop these tools, there are a number of steps that we undertook. So it started with a literature scan to see what sort of scale-up tools already exist. We don't have to reinvent the wheel if there's something that already exists. What are some ways that we can adapt that either to the New South Wales health system or where it's supposed to be used, this tool? So at state levels or at national levels, then it involved actually creating the tool based on what was already available. So that part, I can tell you, involved definitely the literature scan, but also a little bit more creativity around what does the tool look like and what will be usable and feasible for people to actually use. And then there was a piece around gathering feedback. So at the end of the day, it's not possible to just create a prototype in isolation without knowing how people are actually going to use it and whether it's going to be helpful. And then using that feedback, obviously refining the tool so that it's optimal both in terms of making sure it covers a whole lot of domains around what we need to consider when in scaling up population health interventions. But then also, is it clear? Are there things that we're missing? Is this usable? Will this be able to be completed by decision makers, or would you need academic sort of rigorous research background to be able to complete this, which we didn't want. We wanted this to be usable directly by decision makers and their teams that are there to support them. And then, of course, the evaluation and user testing after you refine the tool to make sure that it's exactly as we want it to be. So right now, we were doing some research to support the development and testing of a scalability assessment tool. So the draft scalability assessment tool, I'll refer to it as SAT, S-A-T, from now on. It has 6 different components which describe sort of the public health problem, the proposed intervention acceptability and feasibility, levels of efficacy and effectiveness, likely reach and adoption, and fit with strategic context. So it's meant to be a practical extension to support decision makers in scaling up effective population health interventions using the methods that are outlined in the guide. So I used a literature-based snowball methodology to identify existing tools and resources for decision makers to navigate the early scale-up process from assessing the suitability of population health interventions for scale-up to developing a full scale-up plan. And then we consulted content experts to extract relevant details and scan and identify any further resources that would be of potential relevance in developing the tool. And then part of the literature scan also involved a systematic search of ProQuest, open keyword searches, and hand searches of targeted websites to identify further tools, guides, or research related to assessing the suitability of an intervention for scale-up. And then all of this was used to develop a preliminary SAT. So this is what it looks like in draft. It absolutely looks better in the final version. I just didn't have the final copy to show you in the moment, so it does look quite plain. So in the rightmost column is where you would populate the tool using data or evidence of whatever it might be. So that data might be after consultation with stakeholder experts about the acceptability or feasibility. It might include actual data or numbers or statistics that map out what the actual problem is, any information or research around its efficacy and effectiveness. And as I mentioned earlier, it has the following domains. So the problem, the interventions, and it has a list of sub-questions in the second column to describe what are the types of questions you should be thinking about in those different domains to decide whether or not this will make it easier or more difficult or challenging to scale up the population health intervention. The other domain is acceptability and feasibility. So is it actually acceptable to target groups? Will stakeholders be using it? These are really important questions to ask because at the end of the day, if something is effective, we don't know if it'll actually end up translating to those improvements in population health outcomes if we don't get this type of data, and consider this early on as we're deciding whether or not to scale up something. And then, of course, data around efficacy and effectiveness. I think it goes without saying that it doesn't make sense to scale something up if it's not effective, and of course efficacious to make sure that perhaps the actual technology or product or service is useful and actually does improve health outcomes, but then also is it sustainable, and will this actually be used by people? Is it costly? Is it easy to access? And so on and so forth. And then the last few are reach and adoption, which essentially involves similar types of questions, but framed in a different way. And then strategic context, and this piece is also really important around, does it align with the state, regional, and national policy directions? Is there enough time? Will it be scaled up in time? Because time is a really big factor in deciding in sort of the policy scene in terms of decision agendas, and making sure we see actionable outcomes within a particular political period when when the time is right. And then there are questions around, does the intervention address a identified need of funding agencies? And then in terms of the broader strategic context within which it's being scaled up, which includes sort of factors that we might not be able to anticipate ahead of time, but they're questions that we should be asking ourselves so that in whatever context we plan on using the tool, we're able to think a little bit beyond ones that are already identified here. And then, of course, with all of that considered, there's supposed to be some form of a final assessment around the scalability assessment. So beyond this, sorry, a little bit late, our goal was, again, as I mentioned, not just to develop the tool, but then also to examine the feasibility, acceptability, strengths, and weaknesses of the SAT as a tool, and then examine its utility as a decision support tool, and then also the validity of the tool. So to do all that, we decided to use retrospective and prospective case study analyses of the scalability of chronic disease prevention interventions. So essentially, we used a mixed methods approach, and that's currently being undertaken right now. While I'm not in Sydney, there are staff there who are conducting in sort of key informant interviews around a lot of these questions, and then right before, when I was there, I completed the retrospective case analyses. So I can speak to that a little bit more in the end if we have time, but hopefully that's piqued your interest so far. Another piece of what I did was develop program logics for population health training programs. So for this piece, I was working with the population health training unit within the Center for Epidemiology and Evidence. So as you can see here on the right, there are a number of goals for the Center for Epidemiology and Evidence, and part of that is to build capability. So falling within that are these different training programs that they run, and specifically the one that I was able to develop program logic for in my time there is for the Aboriginal Population Health Training Initiative. So that's AFTI, that's the first one. And essentially what I did was, similarly, the New South Wales Health has a guide as a part of their evidence and evaluation guidance series around developing and using a program logic. So I used this to develop the following. So this was one of my first drafts, and as you can see, the goal is to sort of work backwards from what's the aim of the entire program, what are the outcomes that we're aiming for, what impacts will translate to those outcomes, what outputs do we need to create those impacts, what activities are needed to sustain those outputs, and then finally, what inputs do we need for those activities. So as you can see, this was a bit more of an operational side project, but it did give me a lot of insight around what exactly program logics entails, and I'll be speaking a little bit to the impact of all of these projects a little bit later. So I'll zoom through this as well, and you're more than welcome to ask me questions around that. Another one of the big projects that I took on was preparing a manuscript for the AMIS evaluation protocol. So I'll describe that a little bit now. And for this one, I was working with the Aboriginal Health Research and Evaluation Unit. So in Australia, Aboriginal and Torres Strait Islander women suffer from a maternal mortality rate double than that of non-Indigenous women. Their Aboriginal and Torres Strait Islander infants are twice as likely to be low birth weight and 1.5 times as likely to die in the first month of life compared to non-Indigenous infants. As you can see here, this is actually a graph from 1996 to 2015, and you can see the gap. There's at least a 40% gap for over 20 years in the differences in smoking rates during pregnancy between Aboriginal and non-Aboriginal mothers in New South Wales. So this is an extremely large gap. And despite these disparities, little is known about the types of programs and services that can effectively improve the health and well-being of Aboriginal mothers and babies. So recognizing these numbers, in 2001, the New South Wales Ministry of Health established what this is, so the Aboriginal Maternal and Infant Health Service, to help provide culturally competent, community-based antenatal and postnatal care to mothers of Aboriginal babies and the babies themselves, obviously. So this gives you an idea of where these services are located across New South Wales. So there's quite a few now in 2012. And just wanted to talk a little bit more around the evaluation objective. So the goal was to identify and describe the implementation of AMIS at the state and local levels, to explore stakeholder experiences with this complex intervention, investigate the extent to which it's reaching the target populations, investigate its impact on health outcomes for Aboriginal babies and their mothers, and to investigate the costs associated with the implementation of AMIS through an economic evaluation. So you can already see that through this evaluation, we're looking to get information around process-related outcomes in terms of how are people using it, what are their experiences around this, the usage and delivery of this complex intervention from both sides, both Aboriginal mothers and babies and also the stakeholders involved in delivering the service. And then definitely also pairing that with outcome-based evaluation around, is it actually helping the health outcomes? Are the smoking rates during pregnancy decreasing as a result of this service? So that's a potential question that comes out of that. And then, of course, questions like the reach of AMIS. So at the end of the day, we can create a program and know that it's running and it's aimed to target a particular population. But at the end of the day, if the proportion of people it's reaching is less than we hope for it to be, then we're wasting money and resources on something that isn't actually translating to those helpful outcomes in population. So these are really important evaluation objectives. And these are the evaluation components that are tied to addressing those objectives. So they reviewed program documentation. They used self-administered surveys of AMIS managers, qualitative interviews with key stakeholders, conducted case studies of AMIS sites, conducted quantitative analyses of routinely collected data, and they also conducted an economic evaluation around this. So this complements some of the aims that I was mentioning earlier around describing the implementation and identifying the impact through that routinely collected data. So having the quantitative piece along with the qualitative piece with the qualitative interviews and the survey of AMIS managers. The next few projects, as I mentioned, were ones that I took on recognizing that there was something that I could offer that they might not already be aware of, given they don't know everything about my background and what I bring as a researcher to a policy sort of environment. So my goal here was to help improve the research capability among health system players in the ministry, so decision makers and implementers. And to do that, what I did was adapt an existing resource by the Health Forum to suit their needs. So I won't include sort of the questions in jurisdiction, but essentially a lot of these questions are similar to ones that already exist around problem clarification, comparing options, and then also implementation considerations, but specifically finding New South Wales and Australia related sources to help them find that information, because no such resource exists for people who want to be asking these questions when it comes to developing policy briefs or understanding how to set priorities in their regions, to be able to find information around and background around what is the problem, how do we define it, what is the scope of that problem, who does it affect, what are options that could be used to address those problems, and what are some things that we need to keep in mind in terms of, let's say, options that have been tested and evaluated in other settings, but if we were to apply it in the New South Wales or Australian setting, what are some questions we need to ask before doing that? And then the last piece, I'll keep it short, is around undertaking a strategic analysis of funding recipients. So as I said, absolutely vague, but the goal of this was to sort of analyze the performance of funding recipients and scoping the need for additional policy-relevant deliverables. So the New South Wales Ministry of Health funds certain bodies to conduct certain tasks, and in turn, some of those bodies provide services back to New South Wales Health. So this was about evaluating the quality of services that are provided and identifying, are there more things that we could be asking of these bodies, or are there things that could be better suiting the needs of policymakers and decision makers at the ministry that we need to be communicating to these researchers and these academic institutions around helping us better, helping us use evidence better. So this won't make much sense because a lot of it is very much relevant to the New South Wales context. So essentially the first component, the analysis of the pre-qualification scheme suppliers, is a list of suppliers of those services. So part of the analysis involved finding out how many of those suppliers provided health-related services, and then how many of those are big suppliers, small suppliers, how many people are employed, what types of services do they provide within health, do they offer all that the ministry needs or is it a fraction, and sort of identifying who are the key players that they need to be funding at that time. The second portion around analysis of population health cohort studies is which of those suppliers collect data at a population cohort level that can be used to inform policy decision making. And then lastly, a scan and comparative analysis of knowledge translation programs in Australia, Canada, and the UK. So this was actually really interesting because I could use very directly the information and context that I had working at the forum around what types of knowledge translation programs can exist and what type of quality can be produced at varying timelines, and seeing whether similar services can be offered in the New South Wales context, and who could be providing those things. So this is the part that I wanted to focus on around the impact of the things that I was working on. So for the scalability assessment tool, at the end of the day, I helped create a decision support tool to scale up successful population health interventions, which will be used by several policymakers and decision makers worldwide. I think it still boggles my mind that to this day, right now, there are policymakers and decision makers who are directly interacting with the tool that I built and giving us feedback on what will practically be usable, to the point where it won't just be used in the New South Wales health context, but has already been starting to use in the Victorian state context, and soon perhaps even in other contexts, as I hope to work with partners in the Population Health Solutions Lab in the Toronto Central LHIN around how can the information and experience that I've gained around population health scaling up, seen how can I bring that back to invest back in Ontario and in our Toronto context. I was also able to work with partners at the University of Sydney Prevention Research Collaboration, in addition to a lot of employees at the Ministry of Health, to develop this tool and to test it. So that was really valuable for me to understand how partnerships between academics and sort of policymakers panned out, and the possibilities that are created when you create those linkages. For the AMIS evaluation protocol, one of the reasons why it was so important is because this literature doesn't already exist right now. So it was really important to publish complex evaluation methodology for knowledge dissemination and strengthening health system evaluations across the world. So when people don't know how to evaluate these complex interventions in ways that will actually help us understand how an intervention is working and how to improve it, that'll be really helpful for them to understand the process-related steps that they should be taking before, in the planning stage of scaling up a population health intervention or running a complex intervention, and then also while it's ongoing or after it's finished, to evaluate what went wrong, what went right, and what are things that we want to replicate going forward. It also, the evaluation protocol is also helping identify ways to improve health services for Aboriginal and Torres Strait Islander mothers and babies. So as you can see, the health disparities that I mentioned earlier in relation to the Aboriginal maternal infant health service we're staggering, and it's important for us to be able to understand not just identify that this problem exists and not simply provide a service without following up after, but it's important to understand how can we make sure that the services that we're investing in and have taken time to develop in consultation with community can actually be helpful in improving the health outcomes for Aboriginal and Torres Strait Islander mothers and babies. For the other few projects, I'll still keep going in terms of the impact. So for the program logics, they can be really helpful in planning and goal setting for program initiatives. They can help inform detailed management plans to monitor operations, processes, and functions. They can also help facilitate effective evaluation. So when you know what the outcomes are and you know what sort of impacts you need to deliver those outcomes, and then the outputs for those impacts and activities for those outputs and inputs for those activities, it can help provide that causal pathway and help test your assumptions on what do you think might work. And once you identify what the assumption is, it's easier to pick it apart and understand this might be where the broken link is. This might be where we can improve. This might be what we're taking for granted and what we can change to be doing better with the program. For the finding and using research evidence resource, I think the biggest benefit for this was giving decision makers practical tools to increase the use of evidence in priority setting and policy development. So as much as we as academics want decision makers to be using these tools, if they don't know how or if they don't have the resources to do so, it can be really difficult, or that can be a big gap in sort of the message that we're trying to get across and the actual uptake of evidence in the decision making that goes on. And lastly, for the strategic analysis of funding recipients, I gained a lot of tangible skills around mapping the benefit and scope of services provided, seeing what types of services can be provided in terms of strengthen health systems, and then identifying additional useful deliverables. So it's not just about understanding what's already provided, but going the extra step to see what's actually needed in the ministry and what are some demands that we can create for these bodies that we're funding to better serve our needs. And now to the lessons. I feel like I'm taking a lot of time, but I'll keep going. First of all, so evidence is available for use in many forms, and I think this was one of the biggest things I learned, because especially in the scale-up literature around should we scale this up or should we not, it's not enough to look at quantitative data, and I think that's something I definitely learned, even with the AMIS evaluation, especially when quantitative data doesn't always exist. So research evidence in terms of quantitative research evidence is only one aspect of the big picture. There's expert opinion that's really important at the decision-making level, policy directions, economic and political climate, individual values, skills, capacity, patient needs, organization, culture and climate, and professional interests, so, and other resources. So this is a really big takeaway for me, that we need to be thinking about evidence as more broadly than quantitative numbers. The other lesson I learned was it's really important for us to integrate knowledge translation processes between researchers and decision makers to strengthen health systems. So this sounds a little bit vague, but I'll get into it in a second. So what I found was that oftentimes we tend to place researchers and decision makers as sort of separate entities within the system with sort of opposing approaches for the same interest. So researchers are evidence-based and decision makers are more focused on the context and might not place as much of an emphasis on evidence. And then there are further sort of associations that are made to these two groups around researchers being objective and decision makers being more subjective. Research being research-related and politics being politics. So I noticed that a lot of these dichotomies come up when we talk about health policy, and I think the only way forward is for us to understand that they can't be treated separately, that both of them do have a place and some value in understanding how to actually make decisions, because at the end of the day, to create important evidence, we need to understand what the local context is and what evidence gaps are there. And then also, it's not enough to simply know the context without knowing how well something works. Or just because context is important doesn't mean we can ignore when high-quality research or evidence is actually available, whether it's in the form of expert opinion or qualitative or quantitative. So that's something I definitely learned. Another piece that I wanted to talk about here was that being sort of in the research policy interface, I had a chance to understand a lot of different push, pull, and exchange factors that come into play in knowledge translation. So push factors being producers of knowledge planning and implementing approaches to push the knowledge towards audiences who they believe need it. So to give an example, the project that I undertook around adapting an existing resource for the forum to give decision makers the resources that they need, I was sort of, I guess in a sense, pushing it towards them as a push factor. Pull factors that I also witnessed were around knowledge users, so let's say decision makers planning and implementing strategies to pull the knowledge from sources. So this might even include commissioning evidence reviews. It might include sort of the decision makers understanding the need for this research and then proactively taking a stance on how do we acquire this research and who do we partner with to make sure that we're making decisions that are as evidence-based as possible. And then, of course, what I think I was really happy to see was the exchange piece, which involved bringing both the researcher and the knowledge user communities together through an interactive process either at the end of the project or throughout the research project as a part of an integrated knowledge translation approach. And this is something I saw as well, particularly in the scalability assessment tool, where there was really a joint sort of approach to combining the experience, the contextual tacit experience that decision makers bring, and then also the evidence and sort of rigor that researchers bring to produce a practical tool that will actually be useful. So that's an example I found of the sort of exchange knowledge translation piece. And then I think this is my last lesson. Translational research is crucial to plan for and evaluate whether policy is effective in improving health outcomes. So I think here is part of the point I was making earlier where it's important to consider both the evidence and context to guide decision making. And translational research is the research where you try to understand, okay, something is effective, but how do we make that work in the real world, right? So this is a model that exists. And you can see here already the different types of research that are centered around understanding the problem, which is where a lot of our research, even if you did sort of a bibliometric study around how many studies fall in this type of research, you would find that a lot of it falls in understanding the problem piece and less as we continue along the spectrum to the right. So testing for efficacy might include efficacy studies, and then testing for replicability, and then of course testing for dissemination. So intervention and dissemination studies. And I can elaborate on this a little bit more if anyone has any questions. And then I wanted to end with more fun things around, I went traveling in Sydney and Melbourne. So pictured here is me on the top and the right lower quadrant is me pictured at the Great Ocean Road in Melbourne. And then on the top right, I just took a selfie in the Circular Quay in Sydney. I think photography for me was a really big outlet when I was in Sydney to be able to ground myself in nature and understand sort of the beauty around me. So this was a picture I took at the Blue Mountains National Park as I was this was the first time I'd ever been on a cliff walk in my entire life, and it was quite life-changing. Sydney is really beautiful for coastal and cliff walks, so if you need suggestions, please do email me. This is sort of just an iconic picture. These birds really tormented me in Circular Quay, and I think I found a way to make them look a little bit more attractive than when they were sort of swiping away pizza slices from innocent people who were sitting and trying to enjoy their day. But I make it up to be a lot worse than it is. It's actually really, really beautiful to be walking around this area. This was a picture I took, and I don't know if you can see it, but in sort of the middle of the bridge, you can see the moon. I like to call it moonrise, but it was actually really nice to be able to capture sort of the difference, sort of the contrast between nature and sort of human-built structures. So that was really beautiful. This is a picture I took while walking across the Sydney Harbour Bridge at night, which made for a really excellent view because you can see exactly where the moonlight falls in the water, and you can see the beautiful Sydney Opera House lit up on the right. Really calming, so I would definitely recommend if you go. That's the Sydney Opera House. This is a picture that I took during the Vivid Light Festival that happens. If you are planning on going to Australia, specifically Sydney, I would definitely recommend going when Vivid is on. It's essentially a light show where they have a lot of different types of installations by artists all across Sydney, and they try to project sort of cool art on different sort of monuments that exist in Sydney. So this happens to be the Museum of Contemporary Art that the light is sort of shining on. I think I have another picture here where the light is on the Sydney Opera House. You can see the ferry boats are sort of lit up in different colors to reflect sort of the color and vibrance that exists sort of during that time, especially in Sydney. I don't know if that's, no, that's not the last one. This is from one of my coastal walks. So if you look at the map of Sydney, a lot of it is bordered by water. So, and they actually make it really, they make a lot of different paths that are available through national parks, and they're well maintained. And it's a really great place to be able to see Sydney from different places. If you actually, probably any land that you see here is where I've stepped foot on because I did a lot of walking. So that was really nice to be able to take a picture from each of the peaks. This is all very close to Sydney, and you can see it's already really beautiful and quite different from all the pictures. So this is me here. And then finally, what's next? So I think what I wanted to do was really invest my skills and experience back in Ontario, seeing how I can apply some of the skills and experiences that I've gained to understand what to do better here. And then, of course, something that I'm working on is integrating my background in health sciences with my interests in social equity. The pieces on the right are sort of my interests that I hope will also integrate as time goes on. So in systems thinking, health and social equity, innovation, research, and strategic policy. They sound like a lot of words, and you could probably do a few PhDs in each of those subjects. So I'm going to have a fun time figuring out what I want to do with the rest of my life. And of course, I really do want to acknowledge all the people and institutions that made this possible. So to start, Dr. Levis, Dr. Michael Wilson, James McKinley, Dr. Kaylin Moat from the McMaster Health Forum, the beautiful, wonderful people at New South Wales Health, specifically in those units. I haven't listed all their names because there are quite a few. And then, of course, the Queen Elizabeth Scholarship Program. Without that support, I really wouldn't have been able to undertake such an experience and gain as much as I did out of it. So I'm absolutely really appreciative for them to be investing in youth in the way that they are. And then, of course, the McMaster University Bachelor of Health Sciences program, specifically Dr. Stacey Ritz, Jennifer Landicho, and then the travel scholarship that they were able to award me, because that as well, their support meant the world in terms of making this possible. Thank you.
Thank you very much, Patty. That was excellent. I'm glad that you included those pictures at the end, because I was getting concerned that you were locked in an office the entire time based on the volume of work that they had asked you to do. Normally I would ask the first question, but I'm noticing that we were a little short on time. So what I'm going to do is just ask those who are in attendance if you have any questions, and I'll give you first crack at it. So if you are joining us online, please type your question into the chat box, and I will read it off for Patty and for the sake of the recording. And then if you are in the room, feel free to put your hand up and ask a question, and I will make sure that it gets on for those online. So we have a question from someone in the room. I'll just come to you with the mic and make it easier that way. So here you go.
So just to start off, excellent presentation. I really enjoyed it. I just wanted to ask, because considering how there's also social and health disparities within Indigenous communities in Canada as well, are there any particular learnings that you have from your experience in Australia that you think you can apply to Indigenous communities over here to better their health and well-being?
Thank you. Thank you for that question. I think that's a difficult question to answer, especially because one thing to keep in mind is whenever we're working with Indigenous communities, so for example, first of all, we refer to them as best as we can as Indigenous here unless we know specifically which groups they belong to, in which case we want to be as specific as possible. And you can already notice a difference in New South Wales in that they refer to themselves as Aboriginal and Torres Strait Islanders. So that's a piece around making sure we recognize their identities and around what they wish to be called and how they wish to be addressed. And then I think the transferable pieces come from sort of the approach. So for the AMIS evaluation that I was working on, I mentioned sort of there are values that were sort of surrounding the creation of both the service itself and then also the evaluation. So we want it to be community-based. We want it to be developed in consultation with communities, essentially what that means, right? So it doesn't make sense for a population that's entirely non-Indigenous to be creating things on behalf of people without consulting them at all or involving them in all levels of the process. So that's definitely something that we'd want to apply here in the Ontario context. And then there are pieces around complex evaluation, right? So that's something that is already relatively a rarity around figuring out how do we do that. So definitely the literature around that complex evaluation piece will be helpful if we were to create, first of all, a similar service, a provincial level service for Indigenous communities here, and then also how do we evaluate those things. So I think those are probably the most important aspects there. I think other things that we can do is sort of read up on the recommendations of the Reconciliation Commission. So Indigenous leaders have already identified ways that we can improve, right? So it's really important to be listening in that context and to be actively working towards both engaging them, making sure they are allowed access to positions of power where they can make decisions for their own communities, giving them the resources to do so. So I think it's those type of aspects that are transferable back to Ontario.
You know, when you're here in Ontario, let's say you were to walk around the halls of the Ministry of Health and Long-Term Care, you'll constantly hear the same issues and concerns are constantly being raised. You know, things like wait times, accessibility to health care in the north, home care. You know, these kind of standard issues that we in Ontario we're used to hearing about. They're always at the forefront. They seem to be the main concerns, right? Among others, of course. So now that you've spent time in a ministry in a completely different country, what did you find were the main concerns that you heard or experienced that are always at the forefront of the minds of those in the New South Wales ministry?
Thank you. That's a good question. Also a tough question. So I'm going to think a little bit. I think the first thing that stands out for me is definitely the health of Aboriginal and Torres Strait Islander communities. So that's been a problem, as you can tell, even from the statistics for the past 20 years, at least the smoking and pregnancy rates for Aboriginal and Torres Strait Islander mothers versus non-Indigenous mothers is staggering. So that's been a problem that's also come up a lot. You can also see that reflected in the fact that within the Centre for Evidence and Evaluation, there's an entire unit, the Aboriginal Research, Health Research and sort of strategic, I forgot the name of the unit already, but essentially there's a unit dedicated to developing that evidence base for those communities, both, again, process-related data and then also outcome-related data. So that's definitely sort of a consistent challenge in New South Wales. Probably another piece that, I mean, I think based on where I was situated in the ministry, I had more access to certain conversations, and that probably affects the way that I answer this question. But definitely the piece around lifestyle interventions, so population health level lifestyle interventions. So they have a program called Get Healthy Service that's been in operation for some time. But diabetes, chronic disease is definitely also a big sort of health challenge that the ministry is really dedicated to addressing and puts a lot of resources into. And I think those are the two that come to mind, but I'm confident there are more.
The question I have now is it's about the scale-up model. So you had created this tool that you know, hopefully is going to be used for a long period of time. And I noticed as I was looking at the examples that were on it, you know, my experience with tools like that are, you know, are kind of open to interpretation, a little bit subjective, you know, open questioning that requires people to answer in how they see fit. I'm curious how involved and how detailed the instructions are for that specific tool.
Yeah, absolutely. That's fair. I think as we were developing the tool, we also had those questions around are there instructions we should be giving along with this? And I think what we ended up deciding on was sort of to be clear on what the aims of the tool are, first and foremost, and then also give a few examples. So part of what I worked on in Sydney is populating those tools, so especially the retrospectively, to be able to see how can we use this retrospectively. We're also working on filling out these tools prospectively and sort of describing our methodology around how did we populate it, how do we, essentially, yes, how do we populate it? And then, of course, so before I left, I worked on a research protocol on how we were going to test this, but obviously once that's published as well, I think that'll give a lot of insight into what different stakeholders said about how they were able to use the tool and what was helpful and what was not. And we're hoping for that feedback to clarify on some things around, are these questions too open-ended? Are they clear? Are they, have the examples that we provided, was that helpful? Was that limiting? Are there more questions that we should be asking? So I think we're hoping for that process to inform sort of the instructions and sort of dissemination piece of the tool, because right now we've worked on mainly the examples, but we might need to tweak the tool a little bit as well.
So do you have a tool similar to the SAT in Ontario? And if present, how similar or different are they in terms of supporting policymakers? So in your literature search, did you find anything that was in the Ontario realm?
Good question. In my search, I did not find such a tool. In fact, most of the tools and resources that existed were only addressing parts of the entire question, or in general, there were very few tools and a lot more resources similar to the guide that the New South Wales Health sort of system developed. So some of the frameworks that I found were more international. So the WHO has one, Management System International has one, and we used a lot of those questions to inform the types of areas that we want to address, and then try and make them a little bit simpler and shorter and clearer so that it's a bit more practical for use. So I don't think there is to my knowledge, I don't know of a tool that exists in Ontario that's similar to the SAT. I know in the work that I've started to do now back in Toronto with the Toronto Central LHIN, we have a decision-making framework that's used among LHINs, and that sort of informs priority setting, but even that hasn't been updated in some time, and that's sort of what I've been involved in, because a lot of these questions that we're asking are relevant to scale up, but then also in terms of priority setting, and in terms of what interventions should we be investing in population health for Toronto and beyond.
Thank you, and thank you for the question. I will, looking at the time, draw this to a close. So I want to thank Paddy very much for coming in today and doing this presentation. It looks like you had a wonderful time. You did a lot of very interesting work while you were in Australia, and again, I'm glad to see that you got a chance to enjoy being in Australia by taking advantage of your location. I will just point everybody's attention to the screen for a moment in this slide. The first link that is presented there is just information about our Queen Elizabeth Scholarship Program as offered through the forum if you're interested in it in any way. The second link is a link to all of our webinars. So Paddy's webinar is one of many that we're conducting during this fall term. And of course, we will be having much more in 2018. So refer to that link, that second link, for our full schedule of webinars. And our third link there is to our Queen Elizabeth Scholars or General Forum Scholars blog page. So people like Paddy and other Queen Elizabeth Scholars are writing blogs about their experiences as they travel and are abroad and they come home again. So please visit that link and read their blogs. They're all very interesting and more are added all the time. So thank you again, Paddy. Thank you for coming in. Thank you very much. We appreciate it. And thank you for those who joined us today. And we hope to see you again soon. Bye-bye.